Hi, my name is Alexander Thomson, and I'm a resident in Anesthesiology and Pain Management at the University of Florida College of Veterinary Medicine. The topic of this Vice Rounds video is anesthesia and cardiac disease. Cardiac anesthesia is a complex, evolving, and sometimes controversial topic that's impossible to cover completely in a single lecture. Therefore, this video is meant to serve as an overview of considerations for cardiac patients rather than a comprehensive guide. We'll start with an overview of the cardiovascular system and basic cardiovascular physiology. We'll cover a few key definitions and then delve into the various types of structural heart disease, pre-anesthetic assessment of the cardiac patient, and how to develop an anesthetic plan for a patient with cardiac disease. We'll finish with 3 case examples to illustrate common clinical scenarios. The cardiovascular system encompasses the heart, blood vessels, and lymphatics. Its primary function is to transport critical nutrients, most importantly oxygen, to the tissues, while removing waste products such as carbon dioxide, organic acids, and nitrogen-containing compounds. It also plays important roles in tissue healing, immune defense, and other roles like body temperature regulation and metabolic control. Cardiovascular function is governed by a complex autoregulatory system. Receptors throughout the body integrate chemical, mechanical, hormonal, and neural input to modulate heart rate, contractility, and vascular tone in accordance with the animal's metabolic demands. However, this autoregulation can be disrupted in disease states or as a result of anesthesia. Patients with cardiac disease are often less able to compensate for the hemodynamic changes associated with anesthesia, so special care and planning is prudent to avoid hemodynamic instability and decompensation. At this point in your education, you should be familiar with the normal path of blood flow through the mammalian heart and systemic circulation. If you need to review these concepts, please pause the presentation now, since they're fundamental to understanding the management of cardiac disease. The normal heart beats in response to electrical stimuli generated by the sinoatrial node. These currents travel through internodal tracts to the atrioventricular node, where conduction speed is slowed, allowing time for the atria to contract and eject blood into the ventricles. Depolarizing currents then continue through the ventricular myocardium through the His-Purkinje system. The source, path, and rhythm of these electrical stimuli can be monitored by the electrocardiogram. Abnormalities in the electrical activity of the heart can result in arrhythmias. Excitation-contraction coupling is accomplished by the opening and closing of various ion channels, allowing depolarization and repolarization of the myocardial cells and the release and reuptake of intracellular calcium. It's important to note that the presence of electrical activity in the heart is not always associated with myocardial contraction, and electromechanical dissociation can result in pulse deficits or even cardiac arrest. The complex electrophysiology of the heart is beyond the scope of these rounds, but a working knowledge of the ion species involved can help guide the anesthetist's choice of appropriate therapy in the arrhythmic patient. I've included here a review of the von Williams classification schemes for drugs affecting the cardiac action potential, but this video will focus primarily on structural heart disease, so arrhythmias will not be discussed in detail. At this point, I'd like to briefly pause and go over some key definitions related to cardiac function that are important for understanding how to manage cardiac disease. So the first is cardiac output, and that's the amount of blood pushed into systemic circulation by the heart over a set period of time. It can be represented mathematically by multiplying the stroke volume, or the amount of blood ejected by the ventricle during systole, by the heart rate. This is typically expressed in liters per minute. And the Frank-Starling law of the heart dictates that since the cardiovascular system is a closed system, the cardiac output of the left and right sides of the heart must be equal, and any change in the output from one side or another quickly equilibrates within a few heartbeats. Cardiac output is dependent on preload, afterload, and contractility. Preload is the amount of ventricular stretch that occurs at the end of diastole when the ventricle has filled with blood. Ventricular filling occurs during diastole, so that means that slower heart rates increase preload, since diastole is prolonged and the ventricles have more time to fill with blood. Afterload is the pressure that the heart must work against during systole to eject blood from the ventricles into circulation. Afterload is directly proportional to systemic vascular resistance and inversely proportional to stroke volume. In other words, as systemic vascular resistance goes up, afterload goes up, and stroke volume goes down. All of these variables are interdependent. For example, myocardial sarcomere length affects contractility, and sarcomere length at the beginning of systole is dependent on preload. The result of cardiac contraction and our primary goal for anesthetized patients is tissue perfusion. So when does tissue perfusion occur? Well, tissue perfusion occurs during systole when pressure generated by the ventricular contraction pushes blood through the capillary bed supplying tissues. But when does myocardial perfusion occur? The ventricular myocardium is actually the most oxygen-hungry tissue in the animal's body, extracting upwards of 75% of the oxygen available in blood passing through. So maintaining myocardial perfusion is an important goal under anesthesia. But myocardial perfusion depends on which side of the heart that we're talking about. So the ventricular myocardium is supplied by paired coronary arteries, which branch from the base of the aorta. And in general, coronary perfusion pressure, or CPP, equals aortic pressure minus ventricular pressure. In other words, pressure generated during ventricular contraction opposes blood flow through the coronary arteries. Because left ventricular systolic pressure equals or exceeds aortic pressure, left ventricular perfusion only occurs during diastole. However, pressure in the right ventricle is lower, so perfusion may occur during systole and diastole. That can change though with right ventricular hypertrophy if right ventricular pressure increases. It's important to realize that tachycardia reduces myocardial perfusion time while increasing myocardial oxygen demand. So our goals during anesthesia for patients with cardiac disease are to maintain perfusion, not only of the target tissues, but also of the myocardium itself. And critical to maintaining perfusion is maintaining normal cardiac output. We also want to avoid venous congestion by promoting forward flow of blood through the heart and avoiding high venous pressure. And then lastly, we want to avoid arrhythmias. Arrhythmias can be the result of primary cardiac disease, a secondary effect of disease elsewhere in the body, or iatrogenic factors such as drugs administered to the patient, or the presence of catheters in the heart. They represent abnormal electrical activity in the heart and can result in hemodynamic instability. Let's talk more specifically about the different types of structural cardiac disease that you may encounter in clinical patients. Not all cardiac disease is the same, and your goals for managing one type of cardiac disease may be essentially the opposite of your goals for managing another type of disease. So if there's anything that you take away from this video, let it be that there's no single anesthetic protocol that is safe or appropriate for all cardiac patients. In general, structural cardiac disease can be grouped into one of three major categories: volume overload pathologies, such as degenerative valve disease or dilated cardiomyopathy; pressure overload pathologies, such as pulmonic and subaortic stenosis; or diseases resulting in diastolic dysfunction, such as hypertrophic cardiomyopathy and restrictive cardiomyopathy. One category of structural disease not mentioned on this slide is shunting defects. These are typically congenital defects that are present at birth, and they can range in severity from incidental to life-threatening. By understanding the structural changes associated with each category of cardiac disease, we can predict what effect a change to any given hemodynamic variable might have on a patient. First, about volume overload pathologies, starting with degenerative valve disease, which is a common progressive disease in dogs in which the atrioventricular valves, most commonly the mitral valve, become thickened, deformed, and dysfunctional. And commonly affected breeds include the Cavalier King Charles Spaniel, Cocker Spaniel, and toy breeds such as Chihuahuas, toy poodles, Yorkshire Terriers, Pomeranians, that kind of dog. The result of AV valve degeneration is regurgitant flow from the ventricles into the atria, which can be as high as 50 to 70% of the stroke volume in severe cases. So with time, the increased workload on the left ventricle results in systolic dysfunction, which further compromises cardiac output. Eventually, with sufficient back pressure, fluid can accumulate in the pulmonary circulation, leading to pulmonary edema and congestive heart failure. Mitral valve disease is classified by stage. Stage A includes all dogs that are at risk of mitral valve disease but have no current evidence of it. So, for example, the Cavalier King Charles Spaniel on the previous slide. Stage B dogs have evidence of heart disease, and stage B is further broken down into stage B1 and stage B2, depending on whether the patient has evidence of structural changes to the heart or not. Dogs in stage C have progressed into heart failure or have a history of an episode of heart failure, and dogs in stage D are refractory to standard therapy. The other disease in this volume overload category is dilated cardiomyopathy. Dilated cardiomyopathy results in eccentric dilation of the ventricles accompanied by poor systolic function. It can be hereditary, and it's particularly common in Doberman Pinschers, Great Danes, and Irish Wolfhounds, but recently you may have seen in the news that nutritional causes of DCM linked to taurine deficiency or grain-free diets have garnered some attention in the veterinary community. Dogs with DCM may be asymptomatic and die suddenly, but common presenting complaints include lethargy, exercise intolerance, and respiratory signs. And DCM is associated with arrhythmias and atrial fibrillation, which can cause additional challenges to the anesthetist. Our primary goal for volume overload pathologies is to support myocardial contractility. And the first way we do that is by ensuring that the patient is adequately oxygenated. So a full 4 minutes of pre-oxygenation via face mask prior to induction of anesthesia is particularly important for these patients to increase the oxygen reserve and the functional residual capacity of their lungs. We should also be considering inotropic support for these patients, and my personal preference for patients with volume overload pathologies is dobutamine, because as a potent beta-1 adrenergic agonist with milder beta-2 and alpha effects, dobutamine increases cardiac contractility without significantly altering afterload and your systemic vascular resistance. In fact, decreasing afterload is another major goal for volume overload pathologies, because decreasing afterload will promote forward blood flow. So we do that by decreasing systemic vascular resistance. Unfortunately, many of our anesthetic drugs produce a modest vasodilation that can be helpful in achieving this goal. So drugs like acepromazine, low-dose acepromazine, propofol, alfaxalone, even our inhalants all produce vasodilation that can reduce afterload. But be careful to balance that with the negative inotropic effects that some drugs, especially inhalants, can have. So multimodal anesthesia can be helpful in these patients. Importantly, we want to avoid drugs that increase systemic vascular resistance, such as dexmedetomidine, because dexmedetomidine will both increase afterload and increase preload by dropping the heart rate, and both of those things together will increase regurgitant flow through the diseased AV valve. In severely affected patients, you may consider etomidate because it has a relatively minor effect on the vascular tone, but etomidate is fairly expensive, and it can have unpleasant side effects like myoclonus and gagging and vein irritation. So it's important to use it prudently. Sudden increases in myocardial work as caused by stress and excitement should be avoided. So sedatives should be used to minimize patient strain and minimize patient stress and facilitate restraint. Opioids are fairly safe to use in patients with volume overload disease, but just be aware that they may cause bradycardia, so have a dose of an anticholinergic drug calculated and already ready to go before you give an opioid. You may have heard that benzodiazepines like midazolam are cardiac safe drugs, and that's fairly true, but beware, because in many dogs and cats, benzodiazepines will cause dysphoria and hyperexcitability, so they're likely to be counterproductive when used in a pre-medication, but you can combine them with an induction drug in your induction protocol. Finally, preload reduction reduces volume overload and regurgitant flow, so fluids should be used very cautiously and fluid boluses should be avoided. Bradycardia should be avoided since it results in longer diastole and increased ventricular filling time, which will increase the regurgitant flow. So in summary, for patients with volume overload pathology, avoid increases in preload, afterload reduction and positive inotropy promote forward flow, and bradycardia should be avoided, so be prepared with atropine or glycopyrrolate. Pressure overload pathologies are commonly congenital defects and are relatively common in chondrodystrophic breeds like the French and English bulldogs. Pulmonic stenosis is the most commonly reported congenital cardiac defect in European dogs and second only to patent ductus arteriosus in the USA. Both subaortic stenosis and pulmonic stenosis are the result of a fixed flow restriction in the ventricular outflow tract, which results in a compensatory ventricular hypertrophy as the heart works hard to push blood through a narrowed orifice. The result of hypertrophy and increased work is impaired coronary perfusion, which can lead to myocardial damage, arrhythmias, and heart failure. Dogs with stenosis are commonly managed on beta blockers to reduce inotropy and hopefully delay some of those negative effects. So remember that coronary perfusion pressure is dependent on a pressure difference between the aorta and the ventricle. In dogs with pressure overload pathology, aortic pressure may be the same or sometimes a little decreased, while ventricular pressure is severely increased. So this causes a reduction in coronary perfusion, and drugs that cause further vasodilation and reduction of arterial pressure should be avoided since they can result in myocardial ischemia and acute decompensation. Drugs like phenylephrine should be used to increase arterial pressure without increasing inotropy and myocardial oxygen demand. Likewise, and this is true for almost all cardiac patients, stress, excitement, and pain should be avoided in these dogs, since tachycardia increases myocardial oxygen consumption and decreases the amount of time in diastole for myocardial perfusion. Myocardial ischemia can result in dangerous arrhythmias that further compromise the cardiac output. So, in review, the key points for pressure overload pathology are to maintain an adequate preload, avoid hypotension that could further compromise coronary perfusion, and avoid tachycardia and excitement or anything that could increase myocardial oxygen demand or inotropy. Diseases associated with diastolic dysfunction are the next category of diseases we'll talk about. These diseases are fairly uncommon in dogs, but more common in cats, and they include hypertrophic cardiomyopathy, which results in thickening of the ventricular myocardium and impaired relaxation. Hypertrophic cardiomyopathy increases myocardial oxygen demand and reduces ventricular filling, and severely affected cats may have systolic anterior motion of the mitral valve and left ventricular outflow tract obstruction. In systolic anterior motion of the mitral valve, the anterior leaflet of the mitral valve bulges towards the ventricular septum during systole, resulting in narrowing of the left ventricular outflow tract, which further increases the workload on the ventricle. The large pressure gradient between the left ventricle and the aorta likely contributes to this collapsibility. Restrictive cardiomyopathy is less common. It results in myocardial stiffening, but the end result hemodynamically is similar to that of hypertrophic cardiomyopathy. In this image of a Maine Coon's heart, you can see just how thickened the ventricles can be in cats with HCM and how narrow that left ventricular outflow tract becomes. Increasing systemic vascular resistance in these cases can actually help keep that outflow tract open. So let's talk about our goals with diastolic dysfunction. We want to optimize preload and maintain myocardial perfusion. Fluids should be used judiciously to maintain preload without causing venous congestion. Tachycardia should be avoided since it decreases diastolic time and ventricular filling. And likewise, stress, pain, and excitement should be avoided in patients with HCM since these conditions increase heart rate and oxygen consumption. This is why I'm not a fan of midazolam in cats with HCM since it can cause excitation, but you may consider taking measures like keeping the cat in a dark or quiet room, using EMLA cream or a local anesthetic for catheter placement, and practicing low stress handling techniques. Finally, reducing the pressure gradient between the ventricle and systemic circulation can help keep the left ventricular outflow tract open. Unlike in patients with volume overload pathology, a slight increase in afterload may actually be beneficial for these patients. This is why some anesthetists use low doses of dexmedetomidine in cats with HCM and left ventricular outflow tract obstruction. However, I prefer to use phenylephrine to maintain blood pressure since it's shorter acting and a little easier to titrate. In summary, in patients with diastolic dysfunction, we want to maintain adequate preload since ventricular filling is impaired. We want to maintain afterload and avoid hypotension because hypotension can exacerbate the pressure gradient between the ventricle and systemic circulation, leading to further collapsibility of the ventricular outflow tract. And then finally, we want to avoid tachycardia and excitation because tachycardia increases myocardial oxygen demand and decreases myocardial perfusion. Shunting disorders are most commonly congenital defects that result in aberrant blood flow between the pulmonary and systemic circulation. Because the systemic circulation is typically higher pressure than the pulmonary circulation, most shunts result in left to right blood flow. However, that can change. As the right side of the heart hypertrophies and pulmonary hypertension develops, the flow can actually reverse direction, and that leads to deoxygenated blood entering systemic circulation. In tetralogy of Fallot, the combination of pulmonic stenosis and an enlarged aorta overriding a ventricular septal defect results in right to left shunting of deoxygenated blood. As with other cardiac patients, adequate oxygenation is essential to minimize the consequences of aberrant blood flow between the pulmonary and systemic circulation. You want to maintain adequate preload, but use caution if the patient's in failure. In particular, patients with pulmonary hypertension and right to left shunts are very sensitive to changes in preload, so hypovolemia and vasodilation should be treated aggressively. Changes in systemic vascular resistance can result in altered shunt mechanics, even severe enough sometimes to cause reversal of the shunt. So drugs like propofol have actually been demonstrated to cause clinically measurable changes in shunt flow. So drugs that have a minimal effect on systemic vascular resistance, such as etomidate, are preferable. And then be aware that many of these patients, if they're growing under anesthesia, are juvenile patients, and juvenile patients are different from adult patients. They have higher metabolic rates, differences in drug availability and metabolism, and importantly, an immature adrenergic vasoconstrictor response. And what that means is that neonates are more dependent on heart rate than blood pressure to maintain normal tissue perfusion, so bradycardia is not well tolerated and should be avoided. So, in summary, avoid major changes in systemic vascular resistance that could alter the magnitude or directionality of flow across the shunt. Maintain normal preload and be aware that juvenile patients may require more chronotropic support or different doses of anesthetic drugs and a little more careful planning than adult patients that have fully matured adrenergic responses. Let's talk a little bit about pre-anesthetic evaluation of the cardiac patient. Which patients should be further screened for signs of heart disease? This is a question actually where clinical acumen comes into play because not all heart murmurs are associated with disease. Non-pathologic flow murmurs are a common finding in cats and sighthounds, for example. But on the other hand, not all patients with heart disease will have a heart murmur. For example, up to 60% of patients with structural changes due to DCM don't have a heart murmur, even though they may exhibit respiratory signs or arrhythmias or even sudden death. So therefore, careful physical examination, knowledge of breed-associated risks, and obtaining a thorough history are invaluable tools for identifying at-risk patients. Here are a few general guidelines. Any patient of an at-risk breed which presents with a heart murmur or a history of respiratory signs or syncope should be investigated for cardiac disease. Patients with new or changing murmurs or episodes of syncope or respiratory signs should be further evaluated. But on the other hand, early systolic murmurs that don't last for the entirety of systole are almost never pathologic. They're most commonly flow murmurs. So that's an example of a patient that might have a heart murmur that does not warrant further diagnostic workup prior to anesthesia. That said, if in doubt, it's never wrong to perform more diagnostics to be sure that your patient is safe and that you're well prepared for any events that might occur during anesthesia. A variety of screening tools are available for pre-anesthetic assessment. They may include thoracic radiographs, vertebral heart score, NT-proBNP screening, or even a quick subjective echocardiographic assessment. It's important that if you do identify abnormalities in these screening tests, they should be followed up with cardiology workup and full echocardiogram prior to anesthesia when possible. Obviously, that's not always possible in emergency situations, but definitely prior to elective anesthesia. Patients with a documented history of heart disease should have a cardiology recheck within 6 months of any elective procedure or sooner if clinical signs have changed since the last recheck. Finally, I like to attach an ECG to all of my patients prior to inducing anesthesia, and most patients will tolerate ECG lead placement after premedication, so that allows for rapid identification of arrhythmias. And if for whatever reason there's an emergency situation during induction, it's one less thing to do while you're trying to diagnose what's wrong with your patient. Monitoring patients with cardiac disease is particularly important to identify hemodynamic changes and guide our interventions. An ECG is an invaluable tool for detecting arrhythmias. Whenever possible, like I said, I like to attach the ECG to cardiac patients prior to inducing anesthesia. Capnography is a useful tool because delivery of carbon dioxide to the lungs for exhalation is directly dependent on cardiac output. So in addition to its utility for monitoring ventilation, capnography is an essential tool for early detection of hemodynamic crises. Pulse oximetry provides information about oxygenation as well as pulse pressure. Variability in the plethysmograph waveform can be used to predict fluid responsiveness in patients that may be hypovolemic. And then close monitoring of blood pressure is essential, since small variations that healthy animals would tolerate can have major hemodynamic consequences in cardiac patients. The gold standard for blood pressure monitoring, of course, is by placement of an arterial catheter, but oscillometric or Doppler devices can also be used in its stead. Central venous pressure is infrequently used, but may be beneficial in patients with severe cardiac disease. It's proven to be fairly unreliable in predicting fluid responsiveness, but monitoring changes in central venous pressure may yield insight into sudden changes in cardiac function and tissue perfusion. Remember that tissue perfusion pressure is systolic arterial pressure minus central venous pressure, so high central venous pressure reduces tissue perfusion and has been associated with venous congestion, reduced tissue perfusion, and end organ damage like acute kidney injury. Finally, monitoring the patient temperature is important since body temperature has a direct effect on metabolic rate, oxygen consumption, and susceptibility to anesthetic drugs. So let's move on to a few clinical cases to demonstrate these concepts. This is Luna Carroll. Luna is a 14-year-old spayed female Chihuahua. She was just dropped off at your clinic today for a dental, and she has grade 4 out of 4 periodontal disease with multiple mobile teeth. She also has a grade 3 out of 6 left apical systolic murmur and a history of an intermittent dry cough for 3 months. So at this point, I'd like you to take a moment and just think about what other information you'd like to know about Luna before proceeding with her anesthesia today. So we have a little more background information on Luna Carroll. She was hospitalized 1 month ago for suspected congestive heart failure. During her recheck 2 weeks later, she was diagnosed with stage C mitral valve disease by a cardiologist. And at that time, her LA to AO ratio was 2, so that is elevated. Typically, the upper end of normal is around 1.4 to 1.6. And she is currently on pimobendan, benazepril, and furosemide. So another few questions to consider. What conversation will you have with Luna's owner today about the procedure? What recommendations will you make prior to anesthesia? And what considerations should you take into account when designing Luna's anesthetic protocol? Luna has severe dental disease, and while it's tempting to cancel her procedure because she has heart disease and is at an increased anesthetic risk, we have to weigh her increased anesthetic risk against the risk of not performing the procedure. And given the severity of her dental disease, it's likely that that disease process is significantly affecting her quality of life. So it is reasonable to proceed with the procedure as long as we have all of the appropriate information that we need so that we can develop a plan that minimizes her anesthetic risk. An ECG and thoracic radiographs wouldn't be a bad idea prior to anesthesia for Luna. Even though she has been already diagnosed with heart disease, we want to make sure that her current treatment plan is managing her signs appropriately. And in the same vein, if the owner has a record of her respiratory rates since her discharge from the hospital, that would be important information to know as well. Luna is on benazepril, which is an ACE inhibitor, and ACE inhibitors have been shown to result in refractory hypotension under anesthesia, and that can make our patients very difficult to control. So if possible, the benazepril should not be given the morning of anesthesia. The other two drugs that she's on, the pimobendan and the furosemide, can be given as normal. Pimobendan is going to help us because it increases contractility, and the furosemide is going to decrease the preload. For Luna and also for any patient that you're going to be anesthetizing, emergency procedures and drug doses should be planned before an emergency happens, because if an emergency happens, you don't have time to waste in calculating emergency drug doses. Also ensure that your necessary monitoring equipment is both available and functioning before we give any medications to Luna. Our goals for Luna are to avoid increased systemic vascular resistance because we want to promote forward flow and reduce the regurgitant fraction. We want to avoid bradycardia because bradycardia is going to increase preload by allowing for more diastolic filling time. We want to promote positive inotropy and help her heart contract with as much force as it can potentially muster. So support with pimobendan and drugs like dobutamine is going to be helpful. And then this is somewhat controversial, but since Luna has a recent history of congestive heart failure, we should probably avoid NSAIDs in her. NSAIDs will disrupt the kidney's ability to auto-regulate its own perfusion, and in congestive heart failure, the perfusion of the kidney may already be compromised, so adding an NSAID on top of that can be adding insult to injury. So for her anesthesia protocol, we ended up giving her methadone 0.4 milligrams per kilogram IM. Methadone is a full mu agonist opioid, so it's excellent for analgesia. It tends to be a little less sedating than some of our other opioids, but Luna was a pretty easygoing dog. We placed an IV catheter in the right cephalic vein and induced her with etomidate, around 1 milligram per kilogram IV, and midazolam 0.2 milligrams per kilogram IV. As I said earlier, etomidate can have some unfortunate side effects like gagging or myoclonus, and oftentimes we'll incorporate midazolam into the induction protocol to provide a little bit more muscle relaxation and avoid some of those side effects. She was maintained on 1.5 to 2.5% sevoflurane and 100% oxygen, and during anesthesia she did develop some hypotension and was treated with a dobutamine CRI at 5 micrograms per kilogram per minute. And like I said before, that's going to promote positive inotropy without increasing afterload significantly. So that was Luna. Now we'll talk about Buster. This is Buster Hayes, and he is a 5-year-old neutered male indoor-outdoor domestic shorthair cat. He came home 3 days ago non-weight bearing on his left pelvic limb with some superficial abrasions and bruising, so he was presented to your emergency clinic and hospitalized over the weekend. Radiographs demonstrated a comminuted left femoral fracture, and physical exam revealed a grade 3 out of 6 pansystolic parasternal heart murmur. So take a minute and just consider what other information that you want to know about Buster. So thoracic radiographs that were performed at intake showed no sign of congestive heart failure, but his vertebral heart score was 8.4, and normal for a cat is less than 7.3, so his heart was a little bit enlarged. And over the weekend, he had an IV catheter placed under dexmedetomidine sedation, and he's currently on LRS at 60 milliliters per kilogram per day. He's also on a fentanyl CRI for pain management and robenacoxib, so on CR, an NSAID commonly used in cats. Before you anesthetize him today, you consult with your cardiologist who performs an echocardiogram and diagnoses Buster with hypertrophic cardiomyopathy with systolic anterior motion of the mitral valve. So a few more considerations. What are our goals for Buster's anesthesia today? And what drugs could we consider for his protocol? And what non-pharmacologic considerations might help Buster? So as we design an anesthetic plan for Buster, let's consider a few things. Buster has hypertrophic cardiomyopathy, so his diastolic function and ventricular filling are impaired. We need to use fluids judiciously in order to optimize his preload without causing venous congestion. So a maintenance rate of fluid is probably appropriate for him at this stage until he proves that he needs something else. Tachycardia should be avoided since it reduces ventricular filling time, increases myocardial oxygen consumption, and compromises myocardial perfusion. Therefore, avoiding stress and excitement are very important here. So you might consider keeping Buster in a dark, quiet room, keeping him away from dogs and loud noises that could cause him stress, and then excellent analgesia is important to prevent tachycardia due to pain and discomfort. And we know that he probably is in a significant amount of discomfort after being likely hit by a car and having his femur fractured. So finally, we want to avoid hypotension in Buster since increasing the pressure gradient between his left ventricle and aorta could lead to increased collapse of the left ventricular outflow tract with his systolic anterior motion of the mitral valve. So fortunately, Buster's IV catheter was previously placed under sedation, and that was with the help of Emla cream. So Emla cream stands for a eutectic mixture of local anesthetics. It's 2.5% lidocaine and 2.5% prilocaine. And if you apply it to the skin approximately 30 minutes before IV catheter placement, it can provide some local analgesia and help you out with patients that are averse to needle sticks. Minimal stress handling helps prevent excitement that could be detrimental to his hemodynamic stability, so just making sure that we're going slowly with him, being gentle, not scruffing, that kind of thing. And since Buster already had an IV catheter and he was pre-medicated with a slow bolus of 3 micrograms per kilogram of fentanyl, and then induced with a combination of alfaxolone and midazolam. Since alfaxolone can cause a modest vasodilation and decrease in systemic vascular resistance, it was combined with midazolam, so a reduced dose could be used. Buster was maintained on isoflurane and oxygen in combination with a fentanyl CRI for pain management and MAC reduction, because remember, our inhalants will cause vasodilation, which is going to be something we want to avoid in a cat with HCM and systolic anterior motion of the mitral valve. And importantly, Buster got an epidural with morphine and bupivacaine to provide superior analgesia during his amputation. Blood pressure was maintained with phenylephrine. His heart's already hypertrophied and hyperdynamic, so phenylephrine was chosen to increase systemic vascular resistance without increasing contractility and myocardial oxygen demand. This last case is relatively short, but it's meant to illustrate an interesting phenomenon in cardiac anesthesia. This is Fred Gonzalez. He's a 19-week-old male Labrador Retriever. He presented to your specialty clinic for ligation of a left to right PDA that was diagnosed after his primary care veterinarian found a grade 5 out of 6 continuous left basilar heart murmur on physical. Fred was premedicated with methadone, 0.4 milligrams per kilogram IM. 2 IV catheters were placed, one in the left cephalic vein and one in the left lateral saphenous vein, and that was in case Fred experienced hemorrhage during the procedure and needed a transfusion. He was induced with etomidate around 1 milligram per kilogram IV and midazolam 0.2 milligrams per kilogram IV, and maintained on sevoflurane, a fentanyl CRI at 0.1 micrograms per kilogram per minute for analgesia and MAC reduction, and atracurium. And atracurium is a neuromuscular blocker we use just to prevent any sudden movements that could cause tearing of the delicate vascular structures being operated on. Fred also had intercostal nerve blocks performed of ribs 3 through 6 on the left for complete analgesia of the surgical site of the lateral thoracotomy. Is what hemodynamic changes can we expect during Fred's surgery? So just after Fred was induced and an arterial catheter was placed, he was noted to have a low diastolic pressure around 35 millimeters of mercury. This is actually common in dogs with PDA because the PDA provides a path between the relatively high pressure systemic circulation and the relatively low pressure pulmonary circulation. Therefore, during diastole, it essentially serves as a pressure relief valve. But then once the PDA was ligated, this pressure relieving effect disappeared, so his diastolic pressure increased to 58 millimeters of mercury. However, within a minute of the PDA being closed, Fred's heart rate dropped from 140 beats per minute to around 90 beats per minute. So what could have caused that? That's actually a manifestation of a cardiac baroreflex, in which an increase in blood pressure decreases the heart rate via a reduction in sympathetic tone. And there's actually a specific name for this baroreflex in the context of PDA occlusion, and that's called the Branham sign. That's all I have. Thank you for watching this video. As I mentioned in the beginning of the video, this is meant to serve as a broad overview of cardiac anesthesia, but there are many more topics not addressed here, such as arrhythmias, stabilization, and cardiopulmonary resuscitation. Please feel free to ask questions in the comments section if you have them, and I will do my best to answer them.